Oh right, it is too warm in my office. Wait, never complain about the weather in Wales when it's warm. If it's warm and sunny, it's a rarity. Whereas the lab, the anatomy lab, is nice and cool. Guess why we like to have nice, cool anatomy labs? Yeah, there are some good reasons why you don't let your anatomy labs get too warm. It's not a good thing. So, last week we were talking about the veins of the upper limb, and I had a few requests, and it's... Look, see, that's supposed to be on. It seems incredibly logical that we should then do the veins of the lower limb, and I also had a couple of requests, so today we're going to do the veins of the lower limb, and there are actually some veins on these models of the lower limb, so that's a good start. Okay, so how are we going to do this? We are going to do the same sort of thing we did last time. There are a bunch of important superficial veins in the lower limb. We'll do the superficial veins, what I have pipe cleaners for, again, so we'll have to make those. Then we'll do the deep veins, and in the lower limb the association between the superficial veins and the deep veins is a little bit important. We'll have a look at the deep veins, we'll follow them, we'll do the superficial veins from like distal, from the foot up to the hip, and then we'll do the same for the deep veins, we'll link those together. And then we need to talk about things like the muscular venous pump, but also we should talk about varicose veins. Why do we get varicose veins? Which veins become varicose? And DVTs, deep vein thrombosis. So the veins in your legs can kill you. What? So how does a blood clot, a deep vein thrombosis in the lower limb, how does it kill people? Why is it so dangerous? We'll have a look. Now, do you remember in the upper limb? See, look, when you've got all the latches down, it doesn't fall apart. Do you remember in the upper limb there was a dorsal venous plexus of veins on the back of your hand? Well, there's also a dorsal venous plexus of veins on the dorsal surface of the foot. This is the dorsal foot, this is the plantar foot. You stand on the plantar foot. And those veins come together and they form a very long vein which runs from here superficially all the way up to the thigh up here. And that's the great saphenous vein or the long saphenous vein. If there's a long one, there's going to be a short one. If there's a great one, there's going to be a small one. So it's this plexus of veins here in the foot that are coming together and forming these other veins. Now, as in the upper limb and as with veins elsewhere in the body, while we talk about an artery following this path, and most people's arteries will follow similar paths and be arranged similarly, the arrangement of veins is much more variable. And if you look at the veins in your forearm and the veins in your leg, you see a lot of subcutaneous veins, and they all look a little bit different in each other. So that we have a couple of major veins that follow a typical route that you should be able to find in everyone or most people, but then there will also be other veins, like a random almost plexus of veins, cutaneous veins under the skin that are also draining blood from the superficial parts of the leg. So we're going to talk about the main veins that we can follow. Right, pipe cleaner time. Right, let's put the elastic bands on. They're going to hold the veins in place. Oh man, I'm going to have to make a really long chain of pipe cleaners to make this vein. It should be fine. Let's go to, where are we? Go to here. Okay, so the long saphenous vein or the great saphenous vein you should be able to find if you look here. So this area of the body has very little subcutaneous fat, and this here, this is the tibia, so this is the medial malleolus of the tibia, right? There's the big toe, so we're on the medial side. Now, just anterior to the medial malleolus of the tibia, that's where you should find, oh look, the start of the great saphenous vein. I should have worn shorts, shouldn't I? Oh, there's more. Yeah, you can just. I'm not going to be a very good demo of the great saphenous vein on myself today. Have a look on yourself, right? Find your great saphenous vein, but it's here. So it runs So it collects that blood from the foot, right? Got the dorsal venous network. We've also got a dorsal vein of the great toe that contributes to it, because that's over to this side. And then, do you see? So it stays superficial. It runs from anterior to the medial malleolus, and is running to the medial knee. It's going to go around to this point here somewhere, and then it's going to kind of keep running up the medial thigh, but it's trying to get to this spot here. So do I just need like a short one now? Right. It's a bit too long. Alright, so imagine, there we go. So it ends like that. So what we've got here is the femoral vein, and the femoral vein is going to pass underneath the inguinal ligament here and become the external iliac vein. But more importantly than that is, do you remember when we were talking about the upper limb, we said that essentially these models are showing deeper structures. The reason they don't show the superficial veins is because we've dissected away the skin, so we've dissected away the cutaneous veins, the superficial veins, and we've dissected away the fascia over the top, the connective tissue covering that's holding all this in place. Now the lower limb is covered in like a stocking of fascia, of deep fascia, and we see a bit of that here. This is the iliotibial tract. This is a thickening of that fascia, but the fascia gets called the fascia lata, and it's covering, imagine a stocking covering this entire lower limb. It's holding everything, so it's deep to the veins, right? It's deep to these superficial veins, but it's holding everything in place. That's what fascia does. But there's a hole here, and it is the saphenous opening. And this little hole, so imagine a hole in the stocking there, allows this long saphenous vein to drain into the femoral vein here. So this superficial vein is eventually draining to a deep vein which goes into the pelvis and the abdomen and up. So that's the great saphenous vein. Another important consideration when we're thinking about the veins of the lower limb is that we need to return blood from our feet back up to the heart. How are we going to do that? Is the heart going to suck the blood up? I mean, you imagine having a straw that long and trying to suck the fluid up from doable, but that's some negative pressure you've got to generate. Also, of course, you're pushing blood down the arteries at a higher pressure through the capillaries and then pushing the blood back up again. So you kind of got both things working in action. But the lower limbs, because we are standing up, and we've got quite long lower limbs, the heart needs a little bit of help. And one of the ways of helping the heart return blood from the foot, from the lower limb to the abdomen, is by the use of valves. So there are maybe a dozen valves, I think, in the great saphenous vein, and blood will get pushed up the vein and the valve opens, and then as the blood settles back down again, the valve closes and boom, 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 boom. Yeah. So we don't have the full height of column of blood. We actually have much smaller, shorter columns because we have these columns between the valves. So it makes it easier to return the blood from the foot all the way up the lower limb and back up into the pelvis by the use of valves. That's when the valves work properly. Alright, so that's the great saphenous vein. I know back in the day, the great saphenous vein used to be a target for heart surgeons, for cardiac surgeons. So if you wanted to do a coronary bypass, so if somebody's coronary artery had become occluded, you would take out a section of the long saphenous vein because it's superficial, it's easy to get to, either avoid the valves or flop it around the other way, and then you could use that vein and stitch it into take out the coronary artery bit that's blocked and stitch in a new blood vessel right into that coronary artery, so you could do a heart bypass in that way. Don't know if they still do that, or if they buy, if it's all manufactured tubes these days. Don't know. I'll ask my friendly neighbourhood cardiac surgeon. Right. So that's the great saphenous vein. Now the short saphenous vein runs up here. So the short saphenous vein kind of comes over from this side, but it's running up here. And this is gastrocnemius, and soleus. So this is a vein that's very superficial. Ooh, it's almost long enough. If I pull it up, it's kind of long enough. There we go. It's a superficial vein under the skin. This is a vein you may well see in some very, very skinny people. And it's collecting blood, so there is a dorsal vein of the little toe, and you've got that dorsal venous network. All those blood vessels are coming together. I wonder if the plantar veins also contribute to it, probably. And this is the short saphenous vein, or the small saphenous vein. So this runs underneath the skin, in the calf, and it ends here, so it's draining into, this is the popliteal fossa in the posterior knee. So that's where it passes from superficial to deep to drain into the popliteal vein, and we'll look at those deep veins in a moment, and then the blood carries on back up to the pelvis. Now again, this vein has valves, and it's this vein that you may encounter varicose veins in. So veins don't have a nice muscular wall to them like arteries do. Arteries are used to handling high pressures, whereas veins handle low pressures. But if you've got a column of blood running down here, and the weight of that blood is on the valve, and I said we've got shorter columns, but still, if the vein starts to distend, if it starts to stretch, then the valve starts to become incompetent. It doesn't work very well because it's getting pulled apart, which then puts more pressure on the valve underneath it and underneath it and underneath it and so on. And then the veins have more weight on them, they start to stretch more, and then we start to see those wiggly veins, often in the posterior leg, in the calf here, and those are varicose veins. So the veins are starting to stretch, the valves are starting to break down, and it's kind of progressive. So it's the short saphenous vein you may see that, and you might see it elsewhere in the lower limb as well. But so these are the two big superficial veins of the lower limb, but imagine other cutaneous veins underneath the skin. If you look at your own lower limbs, you'll probably see them. So imagine all of those veins draining into these veins and what have you. Now, I talk about the great saphenous vein coming up here and then passing through the fascia lata to drain into the femoral vein here, but in fact, as the vein ascends, there are a number of connections between the superficial veins and the deep veins. And those perforating veins, because they're perforating through the fascia, also have valves, so there is a one-way flow of blood from superficial to deep veins through those perforating veins. So in fact, I think the saphenous vein, as it ascends and it receives more tributaries, more cutaneous veins draining into it, it doesn't get noticeably larger. If you think about a river, as it gets more tributaries, that river gets bigger and bigger and bigger because it has to handle more water, more flow. Whereas we don't see the same thing in the great saphenous vein, because those perforating veins are constantly sending some blood from the long saphenous vein to the deep veins. So perforating veins. And that relates to the musculo-venous pump, which I'll come back to in a minute, but first of all, let's have a look at the deep veins then. So, elastic band fail. The deep veins run with the arteries. I've done a video on the arteries of the lower limb, so go and have a look at that. Again, this means that you don't need to learn the arteries and the veins of the lower limb separately. If you learn the arteries of the lower limb, then the deep veins match that layout. All right, we just have to add the superficial veins on top. The deep veins run with the arteries, kind of in a vascular sheath, so they're close to the arteries. Supposedly, the pulsation of the artery, the pressure in the artery, helps squeeze blood up the veins back to the pelvis. So they say. But just like in the upper limb, we find that the deep veins often run in pairs, not all the time, but often if we see a single artery in the lower limb, we'll see two veins running with it, often interconnecting as they go. So there are some veins on here. Let's take this apart and see what veins we've got right now. Okay, there's no vein there. This is the anterior tibial artery. So there. I didn't think I'd have to build again. I thought the veins would be on it. Right, let's build again. So have I got a shortish one? So the dorsal venous network here, and the dorsal venous network of veins are also going to contribute to form. So if that's the anterior tibial artery, most likely there will be a pair of anterior tibial veins. I'm not doing a brilliant job of that, but you see how it was. So this is in the anterior compartment of the leg being between the knee and the ankle. So if we take off the muscle layer, then we see the anterior tibial artery. So the two anterior tibial veins will be in there as well, they're not long enough. But do you see how the anterior tibial artery is disappearing there? We've got two bones. We've got the fibula is lateral and the tibia is medial. That's your shin, right? Between the two bones, there's a connective tissue sheet, a membrane, an interosseous membrane that connects the bones and separates the compartments, anterior and posterior. So this means that the anterior tibial artery and the two anterior tibial veins are going to have to pass through the interosseous membrane, and they do that up here to get into the posterior compartment, because if we look at the posterior compartment, again, we're talking about deep veins, so let's dissect a little way. Let's take gastrocnemius and soleus off. So here we see the posterior tibial artery. Oh look, there's a vein starting up there. So the posterior tibial artery would have probably two posterior tibial veins running with it, deep within the leg. And these are forming most likely from plantar veins, medial and lateral plantar veins on the plantar surface of the foot on the underside, just as we see the arteries down here doing. Now there's also another compartment. In the leg we have the lateral compartment out here. So from the lateral compartment there will also be a pair of fibular veins. I can't take these muscles off, so maybe use your imagination rather than me confuse you. But we could pretend, right? So there's the fibula there. These are the fibular muscles. So imagine, oh look, there's the fibular veins are appearing from over there. There they are. They're coming out of that lateral compartment, and they're all converging here. So we have the fibular veins, the posterior tibial veins, and those anterior tibial veins are going through the interosseous membrane. They're all converging here. So all of those deep veins of the calf are converging in this bit here. So this bit in the posterior knee, this is the popliteal fossa. So these veins all come together to form, and we've got that here. This is the popliteal vein here. The model only shows one vein, but there will probably be a couple of popliteal veins. So when you dissect this area, it can be terribly confusing. You've got nerves all over the place, you've got an artery that's making all sorts of funky branches, and you've got a whole bunch of other vessels. If you've got too many vessels, those are probably a pair of popliteal veins coming together. So that's that. And can you see how we've got some little arteries around here? So remember that whenever we look at the blood supply through a limb, as we cross a joint, we find collateral circulation. So we have geniculate veins, genu literally meaning the knee. So geniculate veins are matching these geniculate arteries around the knee. So we've got these little geniculate vein branches around the knee here as well, which are also crossing the knee joint. We get various anastomoses. If we follow the popliteal vein, it's right. So this is the sartorius muscle here. If we take off the sartorius muscle, underneath the sartorius muscle we have this subsartorial canal, and you see how it's going from the lateral to the medial. So it's running to the medial knee here, and look, we can see some veins under here. This is the femoral vein. So the popliteal vein is going to become the femoral vein. So it's going to, this is the medial compartment, your adductors in here. And adductor magnus, so the really big adductor muscle, is going to have a little gap in there, the adductor hiatus. So the popliteal vein will pass through the adductor hiatus, none of this comes off, and it will become the femoral vein, which will run up here into the anterior compartment of the thigh. All right? The femoral vein, as we said before, runs up here, and then as it passes underneath the inguinal ligament becomes the external iliac vein. There is also a profunda femoris vein, so a deep vein of the thigh, which is actually going to be draining most of the blood from these muscles. That's going to be deep under. Oh, do we have that? Nope. You can see some various arterial branches, so imagine some veins running with those guys. But there would be a profunda femoris vein in here, just like there's a profunda femoris artery. So we're at the hip joint, and deep within the hip joint there will also be some circumflex arteries going around the hip, so we'll also find some circumflex veins doing the same sort of thing around them. But that is about it, really. So the other concepts then, the musculovenous pump, so that idea of flow of blood from the superficial veins to the deep veins and then up and into the pelvis, that flow is aided by the muscles contracting and relaxing. So the muscles are within that fascia lata, that thick stocking, so they're kind of compressed already. So as they contract and relax and contract and relax, they squeeze the veins. So that pressure change helps pull blood from the superficial veins into the deep veins. Remember, there's that one-way flow because of the valves, and then helps push the blood up the lower limb in the deep veins as they get squeezed and pushed, and of course you've got the valves to help with that, right? So that is the musculovenous pump. And we all notice this, don't we, when we're sat on long haul flights, or we're sat around in lectures all day and our fingers get fat and our feet kind of get fat and you kind of get a bit swollen. And when we get up and we walk around, that swelling, that extra fluid starts to go away, and that's partly because of that musculovenous pump, but also partly because the lymphatic system is also following the same route. So movement helps draw the blood out of the lower limb and back into the torso. So this is where deep vein thrombosis, DVTs, come in, right? A deep vein thrombosis, so 3 things need to happen really to make a clot more likely to form. One of those factors is slow flow of the blood. So you can see that if you're sat cramped up on a long haul flight and you're not moving, and your legs are beneath you, so your heart's still got to work against gravity to pull the blood up from your feet, you can see how flow might slow down in these deep veins of the lower limb. So a clot becomes more likely to form. It's still somewhat uncommon, but it does happen, as we know. Now, if a clot forms in a deep vein in the lower limb, why is that so dangerous? Well, blocking a blood vessel isn't a good thing anyway. But if you have a clot in a vein and then that clot breaks and you get a lump of a clot flowing with the blood in the vein, well, as the vein ascends the lower limb, it gets bigger and bigger and bigger. So as it gets back into the pelvis, damn it, we're missing bits, but yeah. Pipe cleaners to the rescue. Whatever. The femoral vein is larger than the popliteal vein. The external iliac vein is large. The common iliac vein is large, so the clot will flow through that quite happily. And then we're into the inferior vena cava, which runs up through the liver, still nice and big, no problems there. It'll run up through the inferior vena cava, and the next place it gets to is the heart. So the blood runs up into the heart, and now it's in the right atrium, nice big chamber, run through the right atrium, through the right atrial ventricular valve, into the right ventricle, no problems at all, through the valve up here, into the pulmonary trunk, nice big blood vessel, and now we're into the arterial supply. So the pulmonary trunk is going to split into left and right pulmonary arteries, which will go into the lungs, and then the pulmonary arteries are going to split into lobar branches and branches, and at that point the pulmonary arterial tree, the arteries are going to get smaller and smaller and smaller and smaller and smaller again. So that clot that formed in the lower limb will flow up into the heart, through the heart and into the pulmonary arterial tree quite happily, but eventually it's going to block one of those pulmonary arterial vessels, and then it's blocking blood flow to the lung, right? So now you've got a problem. Maybe it's a small clot and it might give almost no symptoms. Maybe it's a slightly larger clot, so it's blocking more of the pulmonary arterial tree, and gaseous exchange is impaired and you feel breathless, you can't get enough air in, no matter, you know, and maybe you're starting to get pleuritic pain, so when you breathe deeply it hurts as well, so you don't only breathe shallowly because you've got a clot big enough to be irritating the pleura, and that's bad. But maybe you've got a clot that's so big that it's actually blocking, and of course it depends on your particular anatomy as well, because we're all different, but if it's a clot that's big enough to block a significant amount of the arterial tree, so if it's blocking, you know, an early part, then it's not just preventing blood flow into that lung, but it's also preventing blood flow out of the heart, and it's also preventing blood flow back from that lung into the heart. So now you are significantly compromising the cardiovascular system as a whole, and you're affecting the heart. That could lead to cardiac arrest, collapse, unconsciousness, and death. So that's why a pulmonary embolism that forms in the lower limb can be so dangerous. If you get symptoms in your calf, you know, symptoms of or signs of a deep vein thrombosis, you might see a reddening of the skin. It's most commonly in the calf, a swelling, pain, maybe a deep aching pain. Then you should go and see your primary care provider ASAP. Go see your GP, get checked out. We often talk about deep vein thrombosis and the risk with long-haul flights, but there are other associated, other conditions with associated risks, other risk associated, you know what I mean, there are other, you know, so it's not just immobility, there are other things as well that can cause deep vein thrombosis. Anyway, right, that's it, the superficial veins and deep veins of the lower limb. Hopefully that was useful. It's fairly straightforward. It layers on top of your knowledge of the arterial supply to the lower limb. So, alright, cool. I hope that was useful. I'm going to go and get a snack now before I go home. I suppose I'm going to tidy this up, am I?